can start, sir.
You need to unmute yourself, Hitesh.
Hello and good evening. I welcome all the delegates joining us into the product theater on dapagliflozin. And I welcome and I also thank Endocrine Society for giving us the opportunity to host this product theater. So I thank Endocrine Society of India, ESI, and International Society of Endocrinology for organizing such a wonderful event of Endocrine Week 2020. And today with us, we have prominent speakers of different specialities. From endocrine specialty, we have Dr. Bipin Kumar Sethi. From cardiology specialty, we have Dr. B.K. Shastri. And from nephrology specialty, we have Dr. Ratan Jha. So the topic of today's discussion here is looking into dapagliflozin from the eyes of different specialty. So we have named it as a metabolodiuretic promise of dapagliflozin with the sweet spot in heart failure. So as we have been talking since very long that the new dawn in diabetes management. So with dapagliflozin, the new dawn seems to be with us. And now when we see at dapagliflozin, it is not just a molecule for diabetes. It is the molecule for heart failure also. It is molecule for kidney disease as well. So today we have three speakers with us to impart on dapagliflozin science from three different aspects of specialty. So we will start our session with Dr. Ratan Jha. So Dr. Ratan Jha is a senior consultant endocrinologist at Care Hospital, and he is MD Medicine and DM Endocrinology from PG Eimer. He has received silver medal for standing first in the MD program, and he is a professor of endocrinology in Gandhi Medical College of Hyderabad, working as consultant endocrinologist in Care Hospital, Hyderabad, and a lifetime member of ESI and RSSDI. We published 51 national and international articles and papers, and he is a primary investigator of multiple clinical trials. I would not complete my introduction of Dr. Bipin Sethi with these words only, because his introduction will go beyond this one slide. But in respect of the time, so I will pass on the presentation to Dr. Bipin Sethi. Over to you, sir.
Thank you very much. I'll try to share my screen, and it's a very nice feeling that we have got this chance and opportunity to discuss what is essentially a very important topic. And I do hope my slides are visible.
Yes, sir.
This is each time we speak on dapagliflozin, we have to speak of something new. So the term is new this time. The data is more or less what you all already know. I have been asked many times as to you show one new thing in your presentation. So I think the new thing is metabolodiuretic promise of the dapagliflozin. There is some. We are going to talk about dapagliflozin by three different viewpoints. And the viewpoint of nephrologist, Dr. Ratan Jha would be speaking about, and Dr. Shastri, and I and an endocrinologist will speak about the metabolic aspects. Most of you would have seen this picture if you've been to Brussels. This is a picture of a boy who had, according to the folklore, urinated on the wires that were to blow a bomb which would have destroyed the castle of a nobleman. I don't know if that story is true or it's a figment of imagination, but this picture is very popular. And those of you who go to Brussels always will get to see it near the center square. SGLT2 inhibitors have the propensity to increase the glucose excretion in the urine, and nobody ever believed that by that mechanism, they would be able to diffuse the twin bombs, the cardiovascular, and also the renal components of diabetes And now they have extended the benefits beyond the diabetic population. And this is truly revealing. We were controlling this disease by all measures which would reduce glycosuria. And when these drugs were introduced, people were wondering, how could a drug that causes glycosuria actually benefit diabetics? But all of you know that this is indeed the case. We know that there are many issues with diabetes. It is associated with chronic complications, including neuropathy and retinopathy, which are not the topic of discussion today. But there are interactions between the diabetes, cardiovascular system, and renal disease. You have hypertension, coronary heart disease, heart failure with or without vascular disease, and you obviously have issues of NASH, obesity, atherosclerotic diabetic dyslipidemia, and diabetes. In the renal component, which Dr. Jha will be talking about, you have issues of glomerulosclerosis, and you have a crosstalk between the kidneys and the heart, one leading to worsening of the other. In recent times, ever since their introduction, after the initial controversies of tumors, bladder tumors with the SGLT2 inhibitor DAPA was doused, issues of stroke and postural hypertension with canagliflozin were gone. They have come a long way and are approved for use by almost all the guidelines, the ADA, the ASD, ACE, and the cardiologists associations also have pitched in to give their prominence in the disorders that they are so good at managing. The Endocrine Society, RSSGI also have endorsed these guidelines. We know that we have 4 different categories for the sake of simplicity in managing diabetes when we choose anti-hyperglycemic agents. On the extreme left, we have got patients who've got ASCVD or high risk for ASCVD with individuals more than 55, with 50% stenosis of the carotids or the peripheral vascular disease. People who have got proteinuria or CKD. These individuals and those who have heart failure or CKD are suggested to get either GLP-1 analogs or SGLT2 inhibitors. For heart failure and CKD, the predominance is for heart failure, for SGLT2 inhibitors. Second in order is the GLP-1 analogs. When it comes to avoiding hypoglycemia, we have many agents, the DPP-4 inhibitors, the SGLT2s, type glitazones in our country, even for that matter, drugs like GLP-1 analogs and alpha-glucosidase inhibitors. Then you have drugs that cause weight loss, in which you have GLP-1 analogs and you have got SGLT2 inhibitors. And even their cost constrained, people are supposed to use sulfonylureas and or glitazones. Progressively, for various reasons, the cost factor has been erased for the use of DPP-4 inhibitors by some of the companies in our country. The patent violations or the patent expiry of certain DPP-4 inhibitors and certain SGLT2 inhibitors have made the drugs within the reach of many people. So if you look at SGLT2 inhibitors, they are not just in the limited category of patients who got ASCVD, heart failure, CKD, but also as agents that do not cause hypoglycemia, cause weight loss, and also the cost is now being reachable within the range of most people. The ACE guidelines also are somewhat similar, and you would notice that SGLT2 inhibitors are recommended in people who have got atherosclerotic cardiovascular disease, but also as tier 2 drugs in individuals who require dual agents or triple agent therapy. In the kidney disease patients, it is said that they should be given lifestyle modification. First line therapy is metformin, and now the guidelines are saying that you could even start between 30 to 45 at half the dosage. You do not have to worry about metformin, but metformin alone may not be able to control. And because of the benefits that people have seen with SGLT2 inhibitors, they say that it might be appropriate to add these drugs to background RAS blockade with ACE inhibitors or ARBs. Up to GFR 30, we have got now a recommendation to add drugs like canagliflozin. but also up to 2025 might be possible when you have approval for DAPA after the DAPA CKD, which Dr. Ratan will suggest, will discuss. However, one might point out here that the SGLT2 drugs are very good at such GFRs for reno-protection, but they're not such great agents for glycemic control. It says two things. A, the reno-protection is independent of glycemic control, and B, for glycemic control, you may require other agents like D4 inhibitor, insulin, sulfonylureas, or what else you have. The European Society, which I think Shastri will allude to, have placed SGLT2 inhibitors much before metformin in drug-naive people. They say that you might use SGLT2 inhibitors, GLP-1 analogs in patients who are drug-naive and who have got ASCVD, which means that people are at risk because of age, because of dyslipidemia, smoking, and CKD. In individuals who are already on these drugs, they suggest that you must put these people on SGLT2 inhibitors. Inherent in this is the finding that these drugs have benefits not just because of anti-hyperglycemic properties, so they are given independent of HbA1c. That means if somebody is under control with drugs that do not include this, you are suggested to make a change to these drugs even when the person is at target. And this is also relevant for CKD and heart failure when you know that there is data now for patients having benefit even when they do not have diabetes. And what is more, in the DAPA heart failure study, which Shastri will allude to, there was a decrease in the new onset diabetes. We know that heart failure leads to diabetes leads to heart failure. So what nicer thing would be to prevent diabetes in such of heart failure patients. Now, Indian phenotype, we know that we are insulin resistant. We have got abdominal obesity, we have got low levels of adiponectin, and we have got atherosclerotic, atherogenic diabetic dyslipidemia, which is high triglycerides, low HDL, a structurally abnormal LDL, and maybe quantitatively normal LDL. And we have got increased susceptibility to the vascular disease. The glycemic efficacy of dapagliflozin, which we often tend to ignore, thinking that it's only for those subset of patients, is quick in action, is sustained, and the word durability is actually a little bit of a scary word, but it seems to have its action for a fairly long period of time, has been studied for 2 years and more. And it works with any other OADs. It works with blockade of the SGLT2 receptor, so it is not inherently dependent on insulin for its action. In this particular study, up to 1.2% HbA1c reduction has been shown, but it depends on how much is the baseline HbA1c. If your baseline HbA1c is lower, as happens with any other agent, you would have HbA1c lowering just shy of 1%, and most people would agree that HbA1c is of about 8.5. That drug would reduce the HbA1c by a factor which is slightly less than 0.9, which is more than DP4 inhibitors on an average. But these drugs are more effective at higher HbA1cs compared to DP4 inhibitors. Some people feel that D4 inhibitors are better at HbA1cs 8.5 or less. If you look at the durability in this instance with the comparator is lipizide, you find that HbA1c is lowered very rapidly with lipizide, not so rapidly with DAPA, but after a period of time, precisely about 1.5 years, the curves start crossing, and both the things have got an upward kind of an ascent, what we call a Nike phenomenon. But the patients with dapagliflozin tend to have a more blunter steep rise after a period of time. And at the end of the study, the people who were having more lower HbA1c in the group who received the SGLT inhibitor versus sulfonylurea, despite a good impact. And of course, the difference on weight and hypoglycemia were very much there. You know that these drugs do not cause hypoglycemia and they do not cause weight gain. There are many effects on alpha cell function, and some of them are supposed to be responsible for the beneficial effects on the cardiovascular system in terms of the glucagon excess and controlled ketogenesis. But the data on in this respect is very, very confusing. By way of causing glycosuria, they promote hepatic glucose output through glucagon, which means that increases glucagon, and it has been demonstrated. But by improving insulin secretion, they may also have some impact by paracrine action. By somatostatin release, you have tonic inhibition of glucagon. Experiments on the SGLT receptors on the alpha cells have shown that actually there is a decrease in the glucagon concentration. So this is a very complex issue, and some people feel that the indirect effects may be different in different species and sometimes in the same individual, and depends also on the alpha cell mass. This expression is very variable, and therefore you get different results from different studies. And this is shown in this cartoon, which talks about decreasing glucagon as a result of direct stimulation, but paracrine and the other responses are also involved, and you may get different responses in different individuals. Sometimes you have got no response, sometimes you have inhibition, sometimes you have stimulation. There are, of course, extra glycemic benefits, which are weight reduction, which is proportionate to BMI, and blood pressure reduction. Now, weight loss is not just because of calorie losses. Unfortunately, the other mechanisms are just beginning to be understood. And whatever this is, it is not sustained. You lose weight for about 3 to 6 months, and then it sort of plateaus out. They are implicated to shift the energy metabolism towards fat. And they are also supposed to activate AMP kinase and reduce liver lipid content, and therefore they may have some role in the NASH. The regulation of adiponectin and leptin expression also are invoked in modulation of the appetite. If you are lean, you lose less weight, but if you are obese or overweight, you lose more weight. So at the very extreme, when you have got BMI of 18.5, you will have just a very bare minimal loss of 1 kg, but at higher BMIs, when you are more than 40, you lose much more weight. So on average, you stand to lose 2.8 to 3 kilograms of body weight. There are also some mechanisms which are supposed to underlie the pathogenesis and treatment of heart failure and diabetes. We know that the insulin and glucose can work through neurohormonal mechanisms by stimulating the NHE1 activity in the heart and vasculature and NH3 in the kidneys. And this can cause sodium retention and cardiac hypertrophy, and also impair the insulin sensitivity and worsening glycemia. By way of SGLT2 inhibitors, they inhibit NHE3 in the kidneys. It may also inhibit NHE1 in the heart, not directly, but through a binding site on NHE1. Such an action might ameliorate cardiac injury, hypertrophy, fibrosis, independent on their action on the renal sodium absorption or blood pressure. There is also natriuresis, which Ratan Chah will tell you is responsible through tubuloglobular feedback mechanisms to contribute in some ways to reduction of the intraglomerular pressure, amongst other things which with which kidneys benefited. And this will therefore be responsible, along with the RAS blockade, to have a complementary dual action on the efferent and afferent arteriole. Dapagliflozin, as we know, reduces the systolic and diastolic blood pressure. The numbers look 5.1 and 4.2. You may wonder what is this, but you would realize that this translates into significant cardiac and cardiovascular benefits. In summary, patients with type 2 diabetes mellitus at high risk for major vascular complications, heart failure, and CKD. Dapagliflozin has positive impact on metabolic factors, and mind you, controlling diabetes is responsible for reducing the microvascular risk in and by itself, even beyond their action on the kidney and the heart, which the subsequent speakers will discuss. They do reduce HbA1c, weight, and they have some pleomorphic actions like systolic blood pressure, decreasing the uric acid, improving the endocrine function, which the other speakers will speak about. This is the only FDA-approved SGLT inhibitor for treatment of heart failure based on the heart failure study, and might now be also recognized as an agent for kidney disease. Dapagliflozin has also shown, as I said earlier, a reduction in the development of diabetes. So this is one and the only D4 inhibitor which is shown to prevent development of diabetes. We have metformin, we have acarbose, and we have orlistat in the past. We used to also harp upon the glitazones. But amongst the DP4, the SGLT inhibitor, this is one agent. So for glycemic control, for organ protection, for prevention of diabetes, and what you have, including blood pressure lowering and weight loss, not causing hypoglycemia. There are many benefits of SGLT inhibitors, and what you call in Hindi sarvaguna sampanna. So it looks as though if it's used properly, appropriately in patients who do not have contraindications to this and who tolerate this drug well, this drug seems to be a good drug, and it is known to reduce the risk of kidney failure and renal death in patients with the CVD, and also has some action CKD. I will not tread on the toes of my subsequent speakers. Apologies for my voice. The subsequent speakers do not have only beautiful voices, but they also are very good speakers, and it's very difficult for me to compete with them. Therefore, my talk was placed before them. I would hand over the mic to the podium, so to say, to the organizers, and so that the other speakers can present and take you through the journey for kidney and the heart.
Thank you, sir. I would like to thank Dr. Bipin Sethi for the nice presentation from the viewpoint of endocrinologists on dapagliflozin, sir. And sir, you have rightly mentioned the data is similar, but at the same time, sir, when the uses of dapagliflozin is going to increase by multiple clinicians, so the presentation from doctors like you will help in building their confidence in using dapagliflozin. And you have nicely concluded, sir, sarvaguna sampanna molecule, but to be used with the caution and in the right patient, sir. So your presentation is really going to help them in choosing the right patient, sir. Thank you, sir. And today with us, the next speaker that we have is Dr. B.K.S. Shastri. So I welcome Dr. B.K.S. Shastri. B.K.S. Shastri is a HOD of Cardiology Department in Care Hospital, Hyderabad, Telangana. He completed his MD and DM from PGI Chandigarh in 1985 to 90. And he has a special interest in clinical research, pulmonary hypertension, and heart failure. And he has participated in multiple clinical trials as a principal investigator. This is very brief introduction of Dr. B.K. Shastri. And we will have perils of his knowledge during the presentation. So over to you, Dr. B.K. Shastri, sir.
Good evening, everyone. My slides are visible?
Yes, sir.
Yeah. Thank you, Dr. Hitesh Pandya, and thank you, Dr. Bipin Sethi, for making this possible. Bipin has given extensive introduction to dapagliflozin, and now we see how it is useful in the heart failure patients. Now, as you know, the diabetes is a metabolic disease, but with multiple vascular complications. And we have got, it may involve the coronary artery disease, present with heart failure, peripheral artery disease, stroke, retinopathy. You know, all these things are fundamental and basically known to everybody. I have been noticing in my own OP and practice, nearly 40 to 50% of my patients have diabetes, whether it is coronary artery disease or heart failure or present with any other cardiac issues. In general, 40% have coronary artery disease, or 40 to 50% also. Now, as you know, diabetes confers increased risk for coronary disease, MI, and heart failure. Nearly 40 to 45% of the diabetic patients develop heart failure over a period of time, and conversely, nearly 20% of the patients with heart failure will have diabetes, and it increases the higher risk of hospitalization, mortality, whether it is ischemic or non-ischemic. and the morbidity and mortality increase if the person also develops diabetic nephropathy. Now, we know for over a period of years, we know that diabetes control is important, mostly important in the preventing and the microvascular complications, but it also reduces the macrovascular complications, but not when treated alone. As Stenote study has shown, it's not just the hyperglycemia that we have to treat, but we also have to treat associated lipid disorders, hypertension, etc. But somehow, till now, the anti-diabetic agents are not very, very adept in preventing all the cardiovascular complications. Especially glitazones have actually increased the heart failure risk. And from the advanced and accord study, we know that there is problem with the sulfonylureas also. As we see, if the oral hypoglycemic agents, if they cause hypoglycemia, the cardiovascular mortality increases. More severe the hypoglycemia, more severe the mortality. So we require new class of medications which do not prevent, which do not cause heart failure and also do not cause severe hypoglycemia in these patients. So in this class, come the SGLT2 inhibitors. Now, Bipin has dealt with extensively. The mechanism of action includes the diuretic hypothesis, thrifty substrate, and NHE hypothesis, which he has discussed. The diuretic hypothesis basically natriuresis and diuresis it causes, and substrate changes from glucose to beta hydroxybutyrate and glucose increase will be there. And sodium hydrogen exchange hypothesis helps us in understanding how the cardiovascular benefits accrue in this patient with these drugs. And on the right side, you see the renal effects. Apart from they cause these SGLT2 inhibitors cause the afferent arteriolar constriction, thereby decreasing the glomerular hypertension. That Dr. Ratanja will be elaborating in detail. And diuretics and natriuresis and glycosuria and decreased proteinuria, they all cause decrease in the volume and also decrease in the blood pressure, and weight reduction will be there. And all this reduce the afterload. Afterload, to go back to physiology, is the resistance against which the heart has to contract after the onset of contraction. Heart has to pump after the onset of contraction. The preload is also decreased because of the good diuresis, and LV wall stress increase. All these favorably affect the hemodynamics and heart, which are beneficial in the heart failure. And not only that, myocardial energetics in the cardiomyocyte improve. As I mentioned, a better molecule will be there as a fuel, that is beta hydroxybutyrate. And because of the sodium hydrogen exchange inhibition, the intracellular calcium decreases. That will also improve the myocyte action. And as you can see, the sick heart of the diabetic patient remodels with the SGLT2 inhibitors and becomes a healthy heart. This occurs by decreasing the left ventricular hypertrophy, by favorable changes in the cytokines and inflammatory milieu. Extracellular matrix is remodeling occurs, and impaired cardiac metabolism is corrected, and cardiomyocyte apoptosis is corrected. All these lead to, I'll be showing later, the visible changes in the heart structure and function. And as I mentioned, sodium hydrogen exchange is impaired in these patients with heart failure, which leads to increased sodium and calcium. With the inhibition of this sodium hydrogen exchange mechanism, the sodium and calcium decrease in the cytosol, and that improves the cardiac efficiency. And it is said that SGLT2 inhibitors, unlike loop diuretics, they decrease the interstitial edema while preserving the intravascular compartment. Whereas loop diuretics predominantly affect the intravascular volume, vasoconstriction occurs, the more of intravascular volume depletion occurs, whereas SGLT2 inhibitors, it is the interstitial edema that is decreased. So this has a beneficial effect because intravascular volume decreases, the renin-angiotensin system becomes aggravated, which is not good for the heart failure. Now, following the glitazone controversy, FDA mandated that all new diabetic agents should have cardiovascular outcome. With this in mind, the SGLT2 inhibitors were initially studied to see if they are particularly harmful in the cardiovascular arena. When the first study was done, The declared TIMI 58, which is published in 2019 January, this studied in 17,160 patients over 4.5 years, and both primary and secondary prevention with the atherosclerotic vascular disease. And the basic primary endpoint was to see if the major adverse cardiovascular events, that is death, stroke, and MI, are decreased in these patients or not. So what did this study show? This has shown that the primary endpoint, the MACE, there is favorable effect, but not statistically significant. However, the major primary efficacy endpoint, the cardiovascular death for heart failure and hospitalization for heart failure, is significantly decreased compared to the placebo with a p-value of 0.005 for superiority. They are not just equal, they are superior with a odds ratio of 0.83. Similarly, renal composite endpoint is also highly statistically significant, beneficial in these patients. And death from any cause, though it is numerically better, it is not statistically significant. So it has been shown very clearly that the dapagliflozin has favorable effects in decreasing the heart failure related mortality and hospitalization. With this purpose, DAPA heart failure study was undertaken. This was taken in patients with heart failure, both with and without diabetes. And dapagliflozin 10 milligrams daily was added to the standard therapy for the heart failure, especially in patients with reduced ejection fraction. The study included NOHA class 2 to 4 patients. LVEF should be less than 40%, that is heart failure reduced ejection fraction, and NT-proBNP more than 600. If the patient has recent hospitalization, it is 400. If the patient has atrial fibrillation, it is 900 picograms per ml. They excluded patients with GFR less than 30, type 1 diabetes, and the systolic blood pressure is low. After a run-in period, patients are randomized to placebo or dapagliflozin, and they were followed up to 844 events occurred. And what is the patient characteristics? The mean age is about 67 years, and class 2, 3, 4 patients are represented here, though the class 4 is slightly less. Mean EF is 30%, and NT-proBNP is obviously raised, and ischemic, non-ischemic etiology is equally represented. GFR, predominantly half of them have GFR less than 60 ml, and prior heart failure hospitalization seen about 50% of these patients. And coming to the heart failure management, one can say they are excellently managed. The ACE inhibitors, ARBs or ARNI was there almost in 93 or 94% of the patients. And beta blockers were seen in 96, 97%. Mineralocorticoid receptor antagonists about 70%. And a good number of them received ICDs or CRTs. So most of them have standard care is excellent. And what is the primary outcome? The primary composite outcome is CV death, heart failure, hospitalization, or urgent heart failure visit. This endpoint you should know, because many times for various reasons the patients may not be admitted, either because of the social, economic, or cultural factors, or patient may not like to get admitted. So even a visit to the emergency room for heart failure is considered as urgent visit is considered as an endpoint. So this has shown a highly significant decrease with dapagliflozin, the primary endpoint, both in diabetic patients and non-diabetic patients. Dapagliflozin has significantly reduced the primary endpoint. And also CV death and hospitalization, both are decreased. And even primary endpoint decreased, and all-cause death also statistically significant decrease is there in these patients. It is not only the quantity of life that is improved, but even the quality of life, as mentioned by Kansas City heart failure score, has significantly and statistically improvement is there when the patients with heart failure with reduced ejection fraction were given the dapagliflozin. And the benefit is seen not only in patients with diabetes, whether it is there or not, it is favorably dapagliflozin is better. You see all the, in this chart, all the result is onto the left side, or that means which is better. And irrespective of the baseline HbA1c, the benefit is seen in these patients. And what about the safety endpoint? The adverse events, you see, there is no significant difference in any of the adverse events, whether it is volume depletion, renal adverse events, fractures, amputation, etc. None of them is significantly different in these patients, except here, the serious adverse events are obviously more in placebo because of the increased mortality and hospitalization in these patients. So in summary, when added to the standard therapy, dapagliflozin reduced the, mortality due to heart failure, and worsening of the events is less. And relative and absolute risk reduction in death and hospitalization are substantial, clinically important and consistent. And dapagliflozin was well tolerated with hardly any serious adverse event, and rate of treatment discontinuation was very low in these patients. And dapagliflozin gives a new approach in the management of these patients. This is not actually pertaining to the dapagliflozin, but I believe this is a common feature with all SGLT2 inhibitors. In a clinical trial, randomized clinical trial involving 84 patients, at the end of 6 months, the end-diastolic volume, end-systolic volume, LV mass, and ejection fraction all favorably and significantly improved compared to the placebo. And similarly, the exercise parameters also better improved in these patients. This is also not related to the dapagliflozin, but it is considered as a group characteristic, the class effect. And this particular heart failure with preserved ejection fraction, till now we don't have a very good molecule to decrease the morbidity and mortality. And in this particular trial, which was done later, where the heart failure with preserved ejection fraction is a subset of nearly 760 patients, there is a significant reduction in the adverse, the hospitalization mortality in these patients. And we know the relationship between heart and kidney, they are like husband and wife. I often tell my patients, if the patient has heart and renal disease, the risk increases twofold and the treatment choices decrease by half. And we know as the GFR decreases, the mortality increases, the hazardous ratio of the mortality increases as the GFR decreases. And these drugs, SGLT2 inhibitors, dapagliflozin, Dr. Atanjay will be showing us, have a very favorable effect in the renal functions, and GFR decrease is decreased. That indirectly benefits the cardiovascular morbidity and mortality. Compared to other oral anti-diabetic agents like sulfonylureas and DPP-4 inhibitors, there is a significant decrease in the all-cause death, heart failure hospitalization, and all-cause death due to heart failure. Death due to heart failure. All are significantly decreased compared to the comparators. And finally, if one can say, compared to other oral agents, MI is decreased by 19% relative risk reduction, all-cause death about 49% risk reduction, heart failure hospitalization about 36% reduction, stroke reduction is 32%. This is from a meta-analysis in which 74% of the patients were receiving the dapagliflozin. So one can confidently say that dapagliflozin very effectively decreases the all morbidity and mortality due to diabetes. And in the expert consensus statement, it is shown that if the person it is suggested that the person is aged more than 18 years with type 2 diabetes and he has risk factors for atherosclerotic cardiovascular disease, heart failure, or diabetic kidney disease, one has to have the optimal lifestyle modification, including blood pressure control, lipids and glucose, the dietary aspects and antiplatelets, and recommend starting SGLT2 inhibitors or GLP-1 receptor antagonists, proven CV benefits depending on the patient specific factors. And one can select whether SGLT2 inhibitors or GLP agonists, and they can they again manage these patients based on the further response. And how do we start? At the initiation, patients with type 2 diabetes are at high risk of CV disease, already on metformin. If they are below the individual target, switch to non-metformin oral therapies, or if they are on other oral therapies like sulfonylureas, switch to SGLT2 inhibitors. If they are above the target HbA1c, consider SGLT2 inhibitors. Now, how do you select the drug? One can select the CANA, DAPA, or EMPA, and the starting dose for CANA is 100, DAPA is 5, EMPA 10, and one can add to metformin. Consider to limit the non-adherence and pill burden. Now, pre-initiation safety measures, make sure that the patient's GFR is good, and CANA and EMPA can be given if it is slightly less, but for most of the patients, we have to see whether the GFR is calibrated. Sorry. Now, you have to anticipate certain issues, like you have to teach the patients about the genital and perineal hygiene has to be advised, orthostatic hypertension has to be checked, and regular foot examination to prevent any peripheral vascular disease related ischemic infective events. and look for symptoms of decay and avoid excess alcohol, and multi-system care is required. Though it is mentioned that heart failure is one of the drugs, my personal experience is one should be very careful. Don't start them with high dose diuretics. Go slow. Suddenly you expose the patient to high dose diuretics and SGLT2 inhibitors. The dehydration, hypovolemia, hypotension, electrolyte imbalance are possible. So one has to go little slow. And also, this is my personal opinion, maybe Dr. Bipin can clarify, especially elderly women with history of urinary tract infections, or they have got some pre-existing genitourinary abnormalities, cystocele or vaginocele, things like that, prolapse. One has to be little careful in advising these drugs. Otherwise, there can be serious fungal infections of genitourinary tract. In conclusion, dapagliflozin helps in patients with manifest heart failure or those at risk of heart failure. This is from the studies. In the declared heart TEMI study, most of them did not have any heart failure. They were at risk for heart failure. Patients with heart failure in both with and without diabetes, this is shown in the DAPA-HF study. Patient with heart failure with reduced ejection fraction or preserved ejection fraction. And though the glycemic effect may not be good or renal effect may not be seen, for cardiovascular prevention, the heart failure reduction, it seems that you can go up to GFR up to 25 ml. Probably Dr. Ratanja can clarify on it. Probably future studies will show this particular aspect. And now coming to the last slide, the 5 pillars of heart failure with reduced ejection fraction therapy. ACE inhibitors, ARB or ARNI, they are not actually separate. Either we give ACE inhibitors, ARB, ARB or ARNI. This is one of the important components to reduce the morbidity mortality. Beta blockers, of course, one of the pillars. MRA, mineralocorticoid receptor antagonist. Now SGLT2 inhibitors have taken place. These 5 drugs should be considered in any of the patients with heart failure. Finally, one can say SGLT2 inhibitors look more like heart failure therapy than with diabetic agents. Probably one can say they're a heart failure medication with hypoglycemic effects. Thank you very much.
Thank you, sir. Thank you, Shastri sir. And the last line that you have mentioned is very right. It is more of a heart failure therapy than glucose. That's what is first feeling coming with your presentation. And also, sir, if we see by the guidelines, then all the cardiology societies have given it as a second position immediately after metformin. And sometimes they say that you can start along with metformin as a first line as well, sir. Whereas in ADA, if we see, it is mentioned as a second line after metformin only. But yes, sir, as you have rightly mentioned, there are discussions and debates going on, and it will be like at par with metformin, we can say in future, sir. So moving ahead with the next presenter, we have Dr. Ratan Jha with us. Just so. I welcome Dr. Ratan Jha. Dr. Ratan Jha is a senior consultant nephrologist at Virinchi Hospital, Hyderabad, and he is successfully conducting DNB nephrology teaching program since last 15 years. And he is an examiner for DNB nephrology exams as well. And he has published 71 publications from private hospital and has done around 70 oral presentations in various conferences. He has authored multiple chapters in various books, and he has been awarded Fellowship of Indian Society of Nephrology in year of 2011. And Dr. Ratan Jha is having special interest in renal tubular acidosis, RTA, lupus, hepatitis B and C, acid-base electrolyte disorders. He is practicing nephrology since 27 years at Ahmedabad, and he has been awarded as a legend in nephrology in the year of 2017 for Twin Telugu State by Times of India. So I welcome Dr. Ratan Jha, and I hand over the session to Dr. Ratan Jha. Sir, you will have to unmute yourself. Yes, sir.
You able to see my screen or not yet?
Yes, sir. It is visible. You need to present the slide, sir. In the presentation mode.
Okay.
Yes, sir. Now it is visible.
Yes. Good evening, everyone. It is an honor for me to talk in this panel as a nephrologist after Dr. Bipin Sethi and Dr. Sastry about the same drug, how a nephrologist will look at it in his day-to-day practice. The metabolo-diuretic promise or dapagliflozin, or in general, the SGLT2 inhibitors in practice of nephrology in the context of heart failure and kidney disease. This drug as a class is considered to be a drug which I had put a lot of excitement in the minds of nephrologists, because this has emerged as one of the most exciting drug in the current day practice of nephrology, which is going to make a big difference in the outcome so far the kidney disease is concerned and the complications of kidney disease like the cardiovascular outcomes. So in this context, what I would like to highlight is that US FDA has fast-tracked this drug, dapagliflozin, in CKD patients with or without type 2 diabetes to slow down the kidney disease progression and reduce the cardiovascular risk, which is going to be discussed in the subsequent slide. Why it has been fast-tracked. We all know that the kidney and heart interacts in a very complex and bidirectional manner with or without diabetes. And it has been reported that the risk of patients who develop chronic kidney disease, particularly with diabetes, is so high that most of the patients die before reaching the end-stage renal failure requiring dialysis because of the cardiovascular events. And hence, it is very important for us to look at this pathophysiological derangements in a patient of chronic kidney disease, and how we can address it with the evolving kind of therapies which is emerging, particularly the use of SGLT2 inhibitor. Does it make a difference? So the presentation will have certain important points to highlight that the cardiorenal interaction of this drug, particularly in a patient who is diabetic or even not diabetic with a low GFR. So we know that the heart and kidney interacts in a very complex and bidirectional manner. There are certain factors in a patient who has cardiorenal syndrome which impacts the disease progression bidirectionally, which is grouped under the two broad pathophysiological mechanisms: the hemorrhagic mechanism of fluid overload, the renal and cardiac congestion, which interacts with each other to make more damage, reduced perfusion because of reduced cardiac output, and the vasoconstriction in different organs producing a kind of ischemic injury. The neurohormonal mechanism, particularly the two broad categories, are the activation of renin-angiotensin system in a patient of cardiorenal derangement, that is cardiac disease as well as renal disease, and the activation of sympathetic nervous system because of various pathophysiological events. And these are the two important targets in the therapy of a cardiorenal disease. The patient of chronic kidney disease have a third category of special factors which are operative, because which are listed in the third category as chronic inflammation, malnutrition, cachexia and wasting, bone and mineral disorders, that is involves the calcium, phosphorus, PTH metabolism, the acid-base metabolic disorders which ultimately is associated with sarcopenia and malnutrition, and anemia and cardiorenal connection, because anemia is also one of the modifiable factors to treat the cardiorenal pathophysiological events which leads to increased cardiac mortality. So there are three kind of broad targets when a person is having both cardiac disease and heart disease with or without diabetes: the hemodynamic factors, the neurohormonal factors, and the uremic factors, which is to be addressed by the drugs which we prescribe to take care of such patients. So in this context, this is a very important slide which highlights why the dapagliflozin has been approved by US FDA. Dapagliflozin is the only US FDA approved SGLT2 inhibitor for patients with heart failure with reduced ejection fraction to reduce the cardiovascular death and hospitalization from heart failure, as was discussed by our previous speaker. In the context of kidney disease, this drug has been given a breakthrough therapy designation. There is a special kind of abbreviation, BTD, that is the breakthrough therapy designation for DAPA has been granted by the US FDA based on the CKD trials that we are going to discuss, which has shown an unprecedented reduction in the risk of kidney failure as well as the cardiovascular and renal death in a patient of cardiovascular disease and kidney disease. And hence, this drug has been given this nickname of in the current 2020 as a drug of BTD category, a breakthrough therapy for patients of chronic kidney disease. And even the Indian drug controller general DCGI has approved this drug particularly for treating heart failure with reduced ejection fraction, and we are sure that in the coming years this will also get approved for treating patients with chronic kidney disease based on the KDIGO recommendation which is already there. So if we look at what is so special or spectacular about this drug SGLT2 inhibitor as a class in a patient of chronic kidney disease with cardiovascular disease and diabetes, this cartoon shows that in the glomerulus, the anatomy is such that it has a slightly an afferent arteriolar kind of dilatation compared to efferent arterial diameter. So if we look at a normal kind of glomerulus, you'll find that afferent arteriole is slightly more wider than the efferent arteriole so as to maintain an interglomerular pressure for filtration. But when the person is diabetic, there is a marked afferent arterial dilatation or vasodilation which increases the interglomerular pressure, which has a downstream kind of events of increase in proteinuria and subsequent kind of inflammatory injury which happens. So when we are using the drug SGLT2 inhibitor, in a simple way, we can say that it slightly reduces the afferent arterial diameter, that is, it produces afferent arterial constriction, and thereby it reduces the interglomerular pressure. And this reduction of interglomerular pressure is because of tubuloglomerular feedback, that is, the tubule at the level of distal tubule of macula densa sends a kind of signal to the afferent arteriole to constrict, and that is happening through a kind of a kind of chemical which is adenosine. So this is a simplistic way to say how this drug is reno-protective. Normally in a diabetic state with chronic kidney disease and with a progressive disease, there is an increased interglomerular pressure because of afferent arterial dilatation to a higher extent, which is taken care by the SGLT2 inhibitor. And that is how it is theorized to produce a benefit in kidney disease progression. So in this context of the renal protection, dapagliflozin has been used as a drug in 3 important landmark trials based on which the drug is going to be prescribed even by the nephrologist to take care of such patients. The DAPA-CKD trial, the DERIVE trial, and the DELIGHT trial are the 3 important trials which are randomized trials, prospective trials, which have looked at the benefit of dapagliflozin in a patient of chronic kidney disease. One of the most important trial, the DAPA-CKD trial, which is going to form the basis of recommendation by different kind of organizations, is the DAPA-CKD trial. It was a trial which was similar to the Credence trial, which was where the canagliflozin was used for diabetic patients. But this trial has included patients which are diabetic and non-diabetic both. The key inclusion criteria were similar, that is more than 18 years of age, with a GFR in the range of 25 to 75 ml at the time of inclusion. The patient should have a proteinuria of urine albumin creatinine ratio of 200 to 5000 milligram per gram and should be on the maximum tolerated dose of the standard drug ACE inhibitor or ARB for at least 4 weeks, if not contraindicated. The exclusion criteria was the patient should not have type 1 diabetes, polycystic kidney disease, lupus nephritis, or any form of ANCA-associated vasculitis, and should not have received immunosuppression in the last 6 months. So this patient had included both diabetic patients and non-diabetic patients. And this was a multicentric study. More than 4,000 patients were included. And the follow-up duration was of 2.4 years. So this was a kind of randomized placebo-controlled trial. The usual way the randomization was done. The one arm had received dapagliflozin 10 mg once daily, and other arm was having a matching placebo in the follow-up. And then it was analyzed in the follow-up what happened, etc. So what is shown in this slide is how the placebo group matched the dapagliflozin. you will find that all the parameters were matching. There was no kind of difference between the placebo group and dapagliflozin group. There were almost 68% of patients in the dapagliflozin group who were diabetics and 67% in the placebo. The remaining were non-diabetic patients. The blood pressure in the appropriate range, and the eGFR for both the groups were, the mean eGFR was 43 ml per minute, and 97% of patients in both the groups were on ACE or ARB. So that is to say that both the groups were matching so far the demographics were concerned. And this was a kind of trial which included white, black, Asian, others. 35% of the population in this study was the Asian group. So it is applicable to our patient as well. So this trial examined the effect of SGLT2 inhibitor in patients who were having chronic kidney disease. And in this trial, 32% of patients didn't have diabetes. And about 15% of patients had a GFR below 30 ml per minute. That means the patients were having a CKD beyond stage 3 also. Few patients, 15% of patients were in stage 4 kidney disease. So this was a very important kind of inclusion criteria to see whether the patients who were non-diabetics and who were having advanced kidney disease got benefited with the use of this drug. So what was the result so far this trial was concerned is shown in the slide. The primary endpoint and the secondary endpoint of this trial was met. And there was a kind of statistically significant difference between the dapagliflozin group and the placebo group so far the primary and secondary endpoints were concerned. The primary endpoint for this trial was sustained reduction of GFR more than 50, decline and development of end-stage kidney disease or a renal and cardiovascular death. While the secondary endpoint was only limited to the kidney disease. So whichever way we see the benefit of dapagliflozin, it was seen that the patient benefited. Both from the kidney standpoint as well as from the cardiac standpoint, and this was a very statistically significant difference. So it was concluded based on this trial that dapagliflozin patients with chronic kidney disease, if they are prescribed, whether they have diabetes or they do not have type 2 diabetes, it reduced the risk of kidney failure compared to placebo. It reduced the risk of death either because of cardiovascular cause or hospitalization for heart failure, whether they are diabetic or non-diabetic, and it prolonged survival, both the renal survival and the ultimate survival because of lesser incidence of heart failure and heart events. So dapagliflozin was also reported to be well tolerated in keeping with the established safety profile, and there was no difference so far safety issues were concerned between the DAPA group and the placebo group. So this was a very important kind of conclusion from this DAPA-CKD trial, that this drug is not only cardioprotective but also reno-protective even in absence of diabetes. Another trial to support this concept was already done in the past, the DERIVE study, where the efficacy and safety of dapagliflozin in patients with type 2 diabetes with a moderate renal impairment was analyzed. By the term moderate renal impairment, they meant that the GFR was between 60 to 45 ml per minute. And this was the older study, which was done in 2018. And what was found out in the study is shown in the subsequent slide, that when this drug dapagliflozin was used in a patient who had a GFR between 60 to 45 ml and were followed up for 6 months, as expected, the dapagliflozin had some kind of decline in the GFR, because we know that the dapagliflozin is a drug which reduces the intraglomerular pressure, and it is known to have some decline in the GFR, which is ultimately in the follow-up gets normalized. That was seen that by 6 months' time, the dapagliflozin group had a GFR which was coming close to the placebo arm. That is to say that there was no kind of reduction of the kidney function in the follow-up, and this drug was safe at 6 months in the earlier reports of 2018 when it was used over and above the ACE and ARB. And it was reported that when you are using this drug, when the GFR is between 60 and 45 ml, compared to placebo, there was a kind of statistically important reduction of hemoglobin A1C, the fasting plasma glucose, systolic blood pressure, and the body weight compared to placebo arm. That is to say that it was effective at that GFR so far diabetes was concerned, besides the other kinds of pleiotropic benefit that we know is associated with the use of SGLT2 inhibitor in general. So this was the conclusion of this trial, that in patients with type 2 diabetes with CKD stage 3A, dapagliflozin 10 mg compared to placebo significantly improved the glycemic control, the body weight, and the systolic blood pressure. The safety profile was consistent with the established profile of dapagliflozin in general in type 2 diabetic population, as was discussed by our previous speaker, that declared TB trial. There are no adverse event of bone fractures, amputation, or TK was reported in this trial. This derived study demonstrates that dapagliflozin has a good safety profile and is effective in reducing hemoglobin A1C in a stage where it can be used for that purpose. Besides the body weight reduction, blood pressure control when the GFR is between 45 to 59 ml. So that was one of the other trial. The third trial, where this dapagliflozin was used, is the DELIGHT trial, the albuminuria loading effect of dapagliflozin alone or in combination with a DPP4 inhibitor in type 2 diabetes with chronic kidney disease, a randomized double-blind placebo-controlled trial. In this, about 460 patients with known diabetes who were having albuminuria in the range of 30 to 3,500 were included. And the GFR was again the same range of 25 to 75 ml, with the hemoglobin A1C varying between 7 to 11. And all patients were on stable doses of ACE or ARB before this drug was introduced. And they are on glucose loading treatment for at least 12 weeks before they were included in the study. So what was found in this DELIGHT trial was that patients, compared to placebo, whether they used dapagliflozin alone or dapagliflozin with saxagliptin, there was a kind of remarkable kind of reduction of proteinuria with the use of dapagliflozin. With dapagliflozin alone, it was 21% reduction of the proteinuria from the baseline. And when dapagliflozin with saxagliptin was used, it was a reduction of 38%, and it was statistically significant. One has to realize that when you are using a drug, and if the drug is found to have reduction in proteinuria, which is a biomarker for kidney disease progression, this will be a kind of point to say that this drug is going to have a benefit in the follow-up. The proteinuria reduction remains sustained. So that was the thing which was confirmed in this DELIGHT study. What was found in this DELIGHT study was that though the proteinuria was found to be reduced, the body weight and the fasting plasma glucose was not that significantly different compared to the placebo arm. So the ultimate conclusion of this study, the DELIGHT study, was that the dapagliflozin with or without saxagliptin given in addition to angiotensin converting enzyme inhibitor or angiotensin receptor blocker is potentially attractive option to slow the progression of kidney disease in patients with type 2 diabetes and moderate to severe chronic kidney disease, that is GFR till 25 ml. So this was another study which reinforces that there is not only one study which has found the benefit of kidney disease, the worsening with the use of the drug, but other studies also echoed the same kind of finding. So to say that dapagliflozin is now a drug which is just like kind of drug which has produced a kind of extreme excitement in the nephrological circle. It is just like a drug which has produced Thalca or a Kalbali in the minds of nephrologists, because this is one of the drugs which has now come which can help the patient. And in this new era of metabolic disorder management, we have so many trials which supports the use of dapagliflozin as an important SGLT2 inhibitor with diabetes or without diabetes to take care of the cardiovascular renal outcomes. And the trials are the DECLARE trial, the DAPA-HF trial, DAPA-CKD trial, and the CVD real trials, which have looked at different parameters, but have ultimately concluded that the patients are benefited from the cardiac angle as well as the renal angle, and hence it is a reno as well as cardioprotective drug. So that was all that I wanted to talk about the use of this drug in the context of chronic kidney disease, an important drug which should be a part and parcel of all kinds of patients where we are using it for CKD progression. Back to our coordinator for to have this.
Yes, sir. Thank you, sir. Thanks for your words on dapagliflozin from the point of nephrologist, sir. And as you have rightly mentioned, right now it is into the breakthrough designation, but very soon we are expecting that US FDA will give it a designation, a permanent treatment option in a CKD, as well as Indian government is also going to follow the similar thing. And sir, I thank all the speakers, Dr. Sethi, Dr. Shastri, and Dr. Jha for their words on dapagliflozin. And I can reassure that with dapagliflozin being made available to all the patient, and that too as a very reasonable cost, we at Aries are going to take care that all your patients are going to get the best benefit of dapagliflozin. And also we are there to improve the health outcome with many of our patient care initiatives. So I thank all of you again for your presentation, and I thank CSI for Endocrine Week for giving us an opportunity to have this product theater. Thank you, sir. Thanks a lot, sir. Thank you.
Thank you.
Yes.
Thank you.
Thanks. Bye.
Bye.
Good.
Have
Bye,
a good night, sir.
Shastri. Bye-bye.
Bye, sir.
Bye.